bill signed into law July 4th is expected to cut health care expenditures by $1 trillion over the next 10 years. It is the largest transfer of wealth in the history of our country, from the most vulnerable to the wealthiest. It is estimated that between 11 and 16 million people will lose health insurance. The largest cuts will be to Medicaid and to the Affordable Care Act. So what did the Affordable Care Act and Medi-Cal expansion do for our community? In Sonoma County, back in 2014, 14% of our residents were uninsured. With the ACA and the expansion of Medi-Cal, the uninsured rate dropped to 7% in 2015, in 1 year. As of May of 2025, our uninsured rate is down to 5%, thanks to efforts from the state. Medi-Cal funding contributes to the economic vitality of our communities. The UC Berkeley Labor Center estimates that every Medi-Cal dollar spent contributes to $1.85 of economic output to our community through the multiplier effect. Medi-Cal is crucial to the well-being and sustainability of our entire deeply flawed healthcare ecosystem. Dramatic Medi-Cal cuts will increase the uncompensated care by hospitals and clinics. This will drive up private insurance premiums and will financially distress these institutions, resulting... Oh, gracious. You know what? I'm going to sit down here, Mark. Resulting in staffing... Sorry about that. But I'm going to sit down. I can stand up for Q&A. Resulting in reductions in revenues and staffing reductions. The UC Berkeley Labor Center estimates that about 2,000 people in Sonoma County will lose their jobs due to the big, brutal bill's impact on healthcare and allied fields alike. The big, brutal bill has multiple measures that restrict access to Medicaid, and in the state of California, it's called Medi-Cal. Dr. Lisa Ward, Partnership Health Plan's Regional Medical Director for Sonoma and Marin counties, will give you a detailed picture of how these cuts are anticipated to impact our community. Lisa, you have the floor.
All right, here we go. All right, thank you so much, Marie, and thank you for having me. I am going to stand, and let me know in the back if you can't hear me. I'm going to talk about the Medi-Cal cuts that are coming from both the state budget changes and from HR 1. And I'd like to start by just putting some context around how this impacts this northern part of the state and our county. So first of all, I want to say that it's the mission of Partnership Health Plan to help our members and the communities we serve be healthy, period. And Partnership Health Plan is the name of the Medi-Cal insurance plan that serves people all over this northern half of the state. And I think it's probably not a stretch to say that having health insurance is essential to reaching your best health, your highest quality of life, and your longest life. And so we're going to talk a little bit about how, from our point of view as a health insurance plan, some of the legislation that's come down has some limitations for our insured members. In this space of half the state, which extends from Marin County east to the Nevada border and north up to the Oregon border, there's 24 counties. And in those 24 counties, we are the health insurance plan, the Medi-Cal plan for over 900,000 people. This represents 30% of the people in our communities. And to get a little bit more granular, for our Rosa region where I work, there's about 110,000 members here in Sonoma County and almost 50,000 members in Marin County. All right, this is probably one of the most important slides that I use in my work and that I think helps us understand really the timeline of how the different initiatives that are coming down from the state and the federal government can unfold. And so I'm going to talk about probably 2/3 of the things on this timeline, and I'll just point out that I've highlighted the state-driven program changes to Medi-Cal with the star, and then those with the dash are the changes that have come down from HR 1. And then I'll just say that it's important to remember that all of these implementations are happening in the cadence of our typical election cycle, and so the November midterm elections are happening November of 2026, and they're happening really after a lot of the state initiatives are going to be implemented, but before some of the deep cuts from HR 1 are going to be felt in our communities. All right, so the bucket of things that are considered state budget changes to our Medi-Cal program, I'm going to go over these pretty quickly. So first of all, there's several things that change the coverage for this group of people that are called people with unsatisfactory immigration status, this term UIS. And this group of people are Californians, they're adults, 19 and over. They're non-pregnant people because pregnant people have extra access to important health insurance. These are people who are undocumented and who, to this point in time, qualify for full scope Medi-Cal, but now have some limitations on that. So for this group of people with this UIS status, those who are covered right now are going to be able to keep their coverage. What's going to happen going forward, starting in January, is that there will be no new enrollees to full scope Medi-Cal who are in this group. Now there's also a few things that could happen once a person is in this group. If they fall out of the group for any reason, that their redetermination doesn't work or their income changes, etc., they would not be allowed to return and re-enroll. So this is a way that the population who is insured is going to be whittled down. All right, the other thing for this group of people with this unsatisfactory immigration status is that they'll no longer have access to full dental services for preventive and maintenance dental care as adults 19 and over. People will still have access to emergency care for an infected tooth or some kind of extraction, but the regular routine dental care will no longer be available. Now this slide I'm going to talk about quickly because Gabby Bernal, our next panelist, is going to cover some of it. But this is kind of a hodgepodge of different strategies that the state of California has used in the past to improve access, but they don't have to do with health insurance. So first of all, federally qualified health centers like Santa Rosa Community Health Center, Alliance Medical Center, Petaluma Health Center in our area, these are federally qualified health centers, and because they're committed to and take care of very high risk and underserved patients, they actually get higher rates of reimbursement for the care they provide. Well, now going forward, for those people with this UIS status, they're not going to be reimbursing clinics to care for this group of people at that same rate. It's going to actually be significantly reduced, and Gabby will tell you the details. Secondly, the state of California has put in a lot of money to improve access by getting physicians and dentists in primary care out to rural places, underserved places, places where our patients who have Medi-Cal really need to get their care. And so this loan repayment program is coming to an end. Similarly, to kind of entice dental practices to provide dental care and, for all kinds of Medi-Cal patients, they've really needed increased rates because the rates are simply so low they don't cover the cost of care. And so we use supplemental payments to make those rates higher and make it more attractive for dental providers to take care of our patients insured with Medi-Cal. That's coming to an end. And then, just in case you wanted to think about your Ozempic and your Wegovy, the Medi-Cal formulary is changing, and so that medication, those medications when used for weight loss will no longer be available to people who have Medi-Cal insurance. Other insurances, you can go ahead and get your fancy weight loss medicine. All right, so another strategy the state passed that's changing the Medi-Cal program is to reinstitute asset ceilings. We did this in the past in Medi-Cal, but they were removed when we expanded to the ACA. So for adults who are 65 and older, for people with disabilities, and people on long-term care, they're now going to be monitored for their assets. And if people have assets that are deemed above a certain threshold, those people will no longer be eligible for Medi-Cal insurance. So that threshold is about $130,000 for the person with the health insurance, and it could be an additional $65,000 per person in the household. Certain things are excluded, like the home you live in, the car that you own, your retirement accounts, your certain savings accounts, but there are also certain things that are not excluded, like cash accounts and other bank accounts. If you have a second home, for example. So all of those would be added up, and so people are going to be assessed for their level of assets and may or may not qualify for Medi-Cal based on that. Next, the next strategy is actually to take this group, again, that has unsatisfactory immigration status, and they're going to be required to pay what is essentially a $30 per month premium for their health insurance. And so what this does is, if they continue to pay the premium, their insurance is totally fine, but it's another opportunity for what is already an incredibly poor community to miss the opportunity, if they don't pay, to lose their Medi-Cal. All right, that concludes the state program changes, and I'm going to shift over now to those changes that came down through HR 1. So one thing we've already heard a lot about in the news is this term prohibited entities, and that's because it was literally implemented as soon as the bill passed in July. This has to do mostly with abortion providers, like the most famous and well-known to us is Planned Parenthood. So what happened is that a one-year moratorium was put on medical insurance companies like Partnership, and we were prohibited from paying entities, clinics like Planned Parenthood for the medical care that they were giving our patients. And so that moratorium had a court injunction, so that moratorium's been put on hold, and now we can continue to pay for the services being provided. And should that injunction be lifted, it's quite possible this will be a case that's heard in the Supreme Court. What I think is a little bit unknown about organizations like Planned Parenthood is that 80% of the patients that get care at Planned Parenthood, they're insured by health insurance companies like Partnership Health Plan, who insures people with Medi-Cal. And 1 in 4 people in the state of California has visited a Planned Parenthood in the last year. Planned Parenthood provides an incredible amount of primary care, labs, radiology, reproductive health, birth control, testing for STIs or sexually transmitted infections. There's a lot of primary care going on there, not just abortion care. All right, so now this is the second slide that I think is probably the most important thing that I'm sharing with you. Work requirements and the eligibility redetermination are the two things that we are now going to do that are going to predictably have the biggest impact on Medi-Cal enrollment and the ability for our patients, our members, to stay on Medi-Cal. So the first is work requirements. So the requirement is that people have 80 hours of some type of work in a month. So that's essentially half-time work. You could do paid work, volunteer work, community work. You could be in a training or education program. And there's some key groups exempted that make a lot of sense. This is not the whole list, it's a partial list. So young people less than 19, older people over 64, when people get pregnant and the year postpartum, they're exempted, caregivers, and then disabled people for medical diagnoses, mental health, or even substance use disorder treatments will be excluded from the work requirements. However, the way this will be implemented and who decides and who checks off on the hours and are the hours good enough and how do you turn them in, all of that is not decided, and we don't know how that's going to be implemented. And so this feels to us like an area where we may be able to create a system that helps people get through these types of reviews more easily, but it's a huge impact because partnership expects that this is going to impact about 30% of the people in our region here in Northern California. That's about 350,000 people that are going to be impacted by work requirements. So if you don't meet the work requirement, you can lose your Medi-Cal insurance. The next is redetermination of one's eligibility. And so this is going to require people in that expansion group to have their eligibility checked every 6 months rather than every 12 months. So again, it's an opportunity where if people don't get the paperwork in, a signature's missing, there's just opportunity. And we know that people who are eligible for Medi-Cal miss the chance to re-enroll because of administrative misses very often, and so this is a way people may fall off being insured by Medi-Cal. We expect that this will affect about 25% of our partnership insured patients are Medi-Cal members, and so that's about 250,000 people. All right, so cost sharing is another strategy that came down in this bill. I like to think of it as a co-pay. That's probably how we feel about these types of things. And so for those adults who are in the ACA expansion that Marie talked about, for those with incomes over the 100% of the federal poverty level, those folks are actually going to have to pay a fee of up to maybe $35, could be $1, could be $35, we don't know yet. But the point is that just imagine that, just think about your rent, think about your mortgage, your car payment, and just think about how much it costs to live in Sonoma County. And so we're asking people who make $15,000 to pay if they go get a radiology test and a specialist appointment, which we do all the time. That's $35 times 2, so you pay $70 to get that care. So just, it serves as another barrier for people to really be able to afford the care that they actually need. All right, so this is a little bit complicated, so I'm going to try to break it down, but the federal legislation basically created regulatory language that made 2 different types of taxes and fees that we use in California no longer kind of legal, and so we're going to have to change the way that we use those funds to get back into compliance with the new federal language. So managed care organizations are taxed. Partnership Health Plan pays a tax like every other plan across the state. The money's put into a big pool. That pool is doubled by a federal government match, and then that pool money is used to pay for primary care providers, obstetricians doing prenatal care, and mental health care providers at a higher rate so that they can provide essentially comprehensive primary care services to people who are insured with Medi-Cal. Secondly, there's a hospital assessed fee. Hospitals put money into a pot, and then that pot is paid out to hospitals when they have a Medi-Cal insured person that's so sick they need to be hospitalized. The hospital gets a higher rate of reimbursement for that care that comes out of this fund. So we're going to have to adhere to new federal regulations that are going to limit the way that we can administer that money to offset some of the extra costs of Medi-Cal. To be determined. We don't know how we're going to do that yet. And then finally, there's a pot of money that's called state-directed payments. And this is actually aimed at hospitals in the safety net. So hospitals that are really focused on caring for the underserved. Rural hospitals, children's hospitals and safety net hospitals. So this is a group of hospitals that gets paid an extra reimbursement for the care they provide to patients because they're doing it for a certain proportion of underserved patients. These are hospitals like Healdsburg District Hospital. This is like San Francisco General Hospital, where we send patients, or Oakland Children's Hospital. These are some of the best hospitals around where our patients go when they need really good care. But those hospitals are going to struggle because their reimbursement rates are going to go down. Now, we expected that some hospitals might decide to close, or that we were a little bit worried that hospitals might stop providing certain service lines, and we've already heard that that's beginning to happen as they put us on notice. So we can see that happening. All right, and this is the final thing in the federal bucket, which is that not only have these, I've talked through several things, but now, in addition, the definition of who has an immigration status that's acceptable and who has this unsatisfactory insurance status, that pool has pushed more people from acceptable or satisfactory to unsatisfactory. And so you can see there's a group of refugees, asylees, victims of human trafficking, and even people from recent conflicts, like people who are war refugees from the Ukraine. They were acceptably here immigrating to the United States, and now because their immigration status is changing, they'll no longer be able to get Medi-Cal because of that status. So we expect across the state that's going to impact about 200,000 people, and again, it's another way to reduce the number of people that have health insurance. So in sum, based on all of the things I talked about from the federal changes, we expect across the state that it's going to impact about 3.4 million people, just the work requirements and the eligibility redetermination checks that are moving from 12 months to 6 months. In our area, in partnerships footprint here in the northern part of the state, that's still around 250 to 300,000 people at risk for losing their health insurance just based on that factor. Again, it's about 30% of our members that are going to face some of these tests for their Medi-Cal insurance. And the HR bill reduces about $30 billion of funding coming to the state for healthcare every year. That is actually a 15% reduction in the total healthcare budget of the state of California. So together, between state changes and federal changes, this represents a major disruption to our medical safety net, and we're going to have to really figure out how to do our best to cover some of these gaps for our communities. Thanks.
Federally qualified health centers have played a crucial role in expanding access to health care for the most marginalized members of our community. Gabby Leroy, the CEO of Santa Rosa Community Health, will introduce you to the role of federally qualified health centers in our community and will give you her perspective on the potential impacts of the big, brutal bill on health centers and the health of our community. Gabby, you've got the floor.
Hello. Good evening, everyone. So I am here as a representative of the safety net. Federally qualified health centers provide comprehensive, high-quality care for millions of individuals throughout the nation. So I'm going to start today with talking about the FQHC, what it is, how we came about, and then talk a little bit about the local impact that we have and how these cuts are going to be detrimental to the work that we have been doing so beautifully as a community health center network across the nation for so many years. Health centers, federally qualified health centers, were a movement born from social justice. So this goes back to the 1960s war on poverty, where a group of civil rights activists and healthcare advocates realized that there were gaps in communities. There was not access to to any kind of medical care, and that people were struggling for access, and communities were not healthy. And so out of that movement, the community health centers were born. So we are built on equity, we are built on dignity and a community voice. And by what I mean by that is that we pride ourselves on making sure that everybody in the community, regardless of immigration status, of any other factor, is always welcome and cared for at community health centers. We also amplify the community voice, and by that I mean that we are here to serve patients, and patients are very much engaged in the care. Federally qualified health centers by mandate have to have 51% of our patients or consumers on our board of directors. So that makes them a very prominent part of our decision making and the design of our health center services. So now I'm going to talk about the here and now. So the tremendous reach of community health centers is illustrated in the next few slides. In 2024, we served over 34 million people across the country. And these are your neighbors, our caregivers, the people who make our coffee, hairstylists, all kinds of people from all walks of life receive care at federally qualified health centers. A lot of minority people, 64% of people served at community health centers are people of color, have low incomes, are publicly insured. That means we take care of a lot of people with Medicare and Medicaid, and a lot of people that are uninsured. So this uninsured percentage is across the nation. Locally and in California, it's much lower because California was one of the states that expanded Medi-Cal to everyone regardless of immigration status if they met the income guideline. So this change is going to be even more detrimental in California because we just have a bigger swath of the population that receives Medicaid. 1 in 10 people in the United States rely on us for healthcare. We take care of all kinds of people, and one of the things that we do really well is always strive to meet the needs, the changing needs of our community. We develop comprehensive programs to take care of the homeless. We provide lots of care to children, lots of well child visits, developmental screenings, so we can catch things when they're early, lots of immunizations. Veterans, we take care of many veterans, and also the aging population. So as you can see, we touch all parts of the community, all age groups. So now locally, at Santa Rosa Community Health, which is the largest community health center in Santa Rosa, we have eight health centers, including 2 dental sites throughout the city. We have a very talented, diverse group of employees, about 600 of them. So not only will these cuts affect our patients, they will also affect the local economy. We were established in 1996 in Southwest Santa Rosa, and our Lombardi campus is still active and thriving, and we are actually about to open a ninth site, which is a pediatric clinic to meet the demand. So although these changes are happening and the word is on the street, our demand is still really high. And I was just talking to Terry earlier today, and he asked me, what are you guys doing? And my response is, we are doing everything we can to continue to serve our community now, right? We are making sure that our patients know that we are here, nothing has changed. We have telehealth visits, we've got lots of appointments, we keep bringing on new clinicians. Our mission is to serve this community, and we're gonna do that until we can't do that anymore. But we are not backing down, we're continuing to provide the service. We are continuing to provide gender-affirming care. We are continuing to provide reproductive care. This illustrates a little bit more of the tremendous impact that we have locally. And I just want to say that this is representative of FQHCs across the country. We are one of many, but we all do this really important work. We serve a lot of people. In 2024, just at Santa Rosa Community Health, we cared for 42,000 people. And as you can see, all different walks of life. People that are uninsured, 50% of our patients are best served in a language other than English. So we have to have a very diverse staff, and our staff are really talented in making sure that patients receive the care that they need in a compassionate way. No judgment, just a healing environment for everyone. This is a little bit more about our impact. And again, I want to say that this is really representative of the tremendous work that federally qualified centers do throughout the country. We provide dental, we provide vision, in 2024, 246,000 encounters. We do a great job with hypertension, controlling diabetes. We take care of people who are HIV positive, and we have a really impressive viral suppression load, and we have a high rate of screening. So one of the things that's unique about federally qualified health centers is that we are really focused on prevention. We want to take care of you now. We want to prevent any kind of disease or any long-term negative impacts to your health. And across the country, federally qualified health centers are paid to do this. So we get a high Medi-Cal reimbursement rate, and then we get extra funding to make sure that we focus on these quality outcomes for patients. All of this will be in jeopardy with less Medicaid patients, less Medicaid funding, less money for quality outcomes. That means that we serve fewer people, and what that means to the individuals is that they delay care. If you don't have insurance, you don't come in for preventative screening, you don't bring your kids in, and then everybody ends up in the emergency room when they didn't have to be there. So just wanted to give you a visual representation of how this system works. So there's a lot of different puzzle pieces that go into funding federally qualified health centers. We get an enhanced Medicaid rate to offset the cost of taking care of the uninsured. We're able to purchase drugs at a lower cost. There's a 340B pharmacy program that gives us additional revenue. We get grants and other grant opportunities only available to FQHCs. So this whole FQHC model of care is really reliant on federal funding. We've had bipartisan support all along. Community health center funding has never been an issue until now. Our enhanced payment rate is in jeopardy, and everything that's happening in this administration contradicts our mandate. Our mandate is to take care of everyone. So this is actually really disorienting for us, because now there's a group of people that we may no longer be able to take care of. A little bit of the impacts of change. So the cost of healthcare is going to go up for everybody, right? Because it's going to be more expensive to take care of the community. The hospitals are going to get inundated, which means that their costs are going to go up. The safety net, all the community health centers that work with the hospitals to make sure that we take care of the patients so the emergency rooms don't have to. And I just want to give an example of this. During COVID, we did so much testing and so much care and so much vaccination, and we did a lot of that because the emergency rooms needed to take care of the patients that really needed to be served in the emergency room. So we took care of everything else so that the emergency rooms could do their work. So this is the primary care safety net network that really supports the hospitals too. Thank you. Another impact is that we're going to have less access, right? There's going to be fewer people that have insurance, means less access at hospitals. The other thing that's really concerning is that I feel like there's going to be a continued deterioration of trust in the healthcare system. It's already fragmented, it's already hard to access, hard to understand, and this is going to cause even more lack of trust and utilization. And the whole community is not as healthy. If your neighbor is not as healthy, the community is not as healthy, there's also a higher potential for public health emergencies and disease outbreaks because fewer people are getting vaccinated. So this is kind of my visual impact of these changes. I also just wanted to bring some faces into my presentation. So these are a variety of health center employees at Santa Rosa Community Health. These people show up every single day, some of them are in the audience today, to take care of our patients with sympathy, with compassion, and with love. And I'm so proud to be part of the Federally Qualified Health Center Network. And lastly, so what can we do? What can you do? What can we do collectively? Stay informed and spread accurate information. We are finding that there's a lot of misinformation out there about these changes, and there's a lot of fear. What we can all do is make sure that our neighbors and our friends have accurate information and are reading reliable sources of information. Stay in touch with your elected officials. We need to keep telling them that this is harmful and this is going to hurt our communities and have long-term impacts on our communities. Donate. All of the nonprofits are suffering from losses. The Redwood Food Bank, community health centers, community-based organizations, Head Start, everybody is losing grant funds, and everybody needs support. Volunteer. An hour, a couple of hours, once a week, we all need help. And connect with us. We'll send you some occasional updates if you're interested in volunteering. And if you're interested, just come visit one of our clinics and see all these tremendous healthcare warriors in action. Thank you.
The VA system is the largest integrated healthcare system in the United States. The big brutal bill does involve some cuts to VA healthcare and is anticipated to increase out-of-pocket expenses for many veterans and has created a back door to extensive privatization of the VA system. Dr. Ginger Schechter will share with you the role the VA plays in serving vets, as well as its contribution to the health care of those of us who are not veterans. Stephen Lewis will be joining her. He is a veteran who will share with you what the VA has meant for his health, his well-being, his life. Ginger, you've got the floor.
Thank you. So thank you everyone for having all of us here today. I wanted to pay a special thank you for asking me. I am truly honored to be here today. Thank you. I want to begin by giving a little background on the Veterans Administration and maybe even expanding your knowledge about what the VA is and what it does. So the VA was founded on the principle that it would, in the words of Abraham Lincoln, with malice toward none, with charity for all, to care for who shall have borne the battle for his widow and his orphan. This laid the groundwork of the government's obligation to care for those who served and the families of those who perished on the battlefield. This led to the establishment of the VA, and today the VA provides to veterans and their families health care, disability compensation, pensions, education and training, home loans, life insurance, and burial services. For family members, the VA also provides survivor compensation as well. And also for veterans and their families experiencing homelessness, the VA has a program that offers case management, temporary financial aid, and housing assistance. The VA has been at the cutting edge for many years with very little fanfare or acknowledgement. And this excellence has touched all of us, whether you are veterans or not. The VA enacted the very first electronic healthcare record system in the United States, and everyone else followed suit. And I can attest to this because I was one of the very first medical students to be using this electronic health record system back in the 90s. It is also the only example we have in the United States of a universal healthcare system. It provides integrated care and is a model for the entire rest of the United States. It's also a leader in outcomes-based research And it developed the model of trauma-informed care that is now used throughout the United States. And the VA trains over 120,000 medical trainees every single year. This includes doctors, nurses, nurse practitioners, social workers, psychologists, and pharmacists. And all of these people go on to jobs in the private sector as well as staying within the VA. So you're touched by these people every single day in your lives. Today, the VA serves over 9 million veterans and over 700,000 family members through the CHAMP VA care system. It has over 170 medical centers and over 1,900 outpatient sites. A few facts that you need to keep in mind when thinking about the VA and how it can affect all of us. Over 1.2 million veterans use SNAP. 50% of veterans use Medicare. And in California alone, 12% of veterans age 19 and older use Medicaid. So far this year, the VA has lost 1,700 registered nurses, 1,000 medical support assistants, over 600 doctors, 200 police officers, 80 psychologists, greater than 1,000 veterans claim workers. They've also had a decrease in applications to fill any position by 45% and a 56% decrease in new employees starting jobs. Veterans have special mental and physical health care diagnoses that are not taught to us in medical school. Those who choose to work at the VA are acutely aware of this, and they're often trained in VA and choose to stay there in order to serve the veterans better. Because of this, the VA has lower readmission rates and fewer post-surgical complications than the private sector. When you lose staff, then you lose critical expertise that is not readily replaced. And if you require veterans to seek care in the community, this will come with higher costs for both the veterans and taxpayers. And also showing less accountability for providers who care for them, and fewer evidence-based practices, and that leads to fragmented care. Project 2025 and its supporters believe that privatization of the VA will lower costs and result in savings for the federal government. This is evident in the fiscal budget for 2026, which increases funding for the VA in order to direct more money to privatization and direct money actually away from VA sites and away from hiring more staff to fill vacant positions. As we are acutely aware, and this is being pointed out today, there aren't enough doctors in the private sector for those of us who need to use the private sector. So imagine more and more veterans being forced to use the private sector as well. So we need to be sure that we are paying attention to this and not losing sight of this. One last thing I wanted to say, what can you do? What can you do as community members? Continue to let your leaders know that you want to see what's happening in the upcoming fiscal budget and you want to have a voice. Also talk to your neighbors, friends, family, and work colleagues about how cuts to the VA will affect all of us, not just veterans and their families. Join our protests every Friday outside the South VA clinic here in Santa Rosa. And don't give up your drive to remain aware of what's going on by joining groups like Indivisible, 50501, Veterans for Peace, and our Facebook group, Veterans for Sonoma County. I want to make sure you know that veterans and VA staff are acutely aware that we're out there every Friday, and they say that it gives them hope and makes them feel seen, heard, and supported. Thank you.
Tonight I represent the patient side of the healthcare system. Our healthcare access is under threat. I'm Sergeant Stephen Lewis, the 351 Civil Affairs Unit of Mountain View, California. I went to Operation Iraqi Freedom in 05-06. I am a singer-songwriter, and I need to get back to those open mics because the music is my joy. And I may not be a doctor, but don't neglect your joy would be a good piece of advice. I was in Tikrit, which is Saddam Hussein's hometown. If you remember that statue that was chopped down and flopping through the streets, that's his palace. I was a signal systems support combo guy. And I encrypted the radios before each mission, but during each mission I was the turret gunner or the driver sometimes. Civil Affairs Unit is like a city planners, basically, or assessors, basically, going out and look at the villages and assess what they need. Usually food, water, shelter, because their shelter is blown to smithereens. We provide food, shelter, clean water, educational supply, toys, things like that. The Civil Affairs hires and pays out the local Iraqi contractors based on that need that we assess. Combat zone. The pressure of not knowing if today is the day that everything's going to go sideways, I think is not hard to imagine. It's not that hard. But it always affects people in different ways because people bring their own baggage with them. So you could ignore it pretty easily as long as nothing happens. The pressure didn't let up at night either due to the crude mortar rounds. You know, they don't have a standing army that we had to worry about. They had some rogue guy out there with a little tube launching stuff, and he was out before it even hit the ground. Those continual pressures played a toll, and plus several events that I found to be morally reprehensible, and one potential violation of the Geneva Convention left me feeling not so great about my service. I lost my friend, Sergeant Cheyenne Willie, over there. He had the idea that we were going to get a couple of Harleys and ride them back home from Fort Bragg. He didn't make it. But the main piece that started this downward spiral for me happened about 4 or 5 months after I returned. I met this young woman over there, just about 24. You know, I was older, I'm an older dude, so nothing like that. But she just had that kind of joy and just laughed a lot and smiled a lot for no apparent damn reason. She's just that kind of person. Kind of nice to be around sometimes. When I got back, I got word from our unit that she'd been killed. She was raped, genitally mutilated, and then beheaded. And the only thing I can imagine is how long it must have taken to torture her for information. She's the catalyst, basically, that eventually started my treatment at the VA. I've always known about my mood swings and my ups and downs through the seasons, so I latched onto this idea of a seasonally affective disorder. It just felt right. But what I learned is that I've already had PTSD from childhood trauma, and that's what was going on throughout my entire life. My second clinical advice is don't take PTSD to a combat zone, if you can help it. I escaped my home by joining the Army in 1985. This is my first enlistment in 1985. My second enlistment was 2004 to 2006. I went to basic training. I went to basic training as my summer vacation between my 11th and 12th grade because I couldn't get out of the house fast enough. What I was leaving was 2 alcoholics, and my stepdad beat my mom 3 or 4 times a year. I watched him put a gun to her head, a knife to her throat, just all kind of manner of whatever obscene control you can really think of. My mom went away for 2 weeks. I hope this isn't too graphic. I don't think it should be. My mom went away for 2 weeks to go to my sister's wedding. While she was away, Ray was going to man me up. I guess I needed manning up for some reason. He always called me a candy ass and mama's boy, so I guess he wanted to fix that. Thought I was broken, I guess. Well, during his 2 weeks, I was his designated driver. And we'd go bar hopping. Because I was the driver, he'd only let me have 2 or 3 rum and cokes, Bacardi cokes, because that's what we drank in Florida. One night we went to a drive-in theater. It was a double feature. One of them was Debbie Does Dallas, if you're familiar at all. From there, he went to pick up a hooker for me. But I wasn't really having any of that. That freaked me out. Just a bit. So, since that didn't work out, he decided to take me to a bookstore that has an open slot view at the viewing window of the whole business. Good stuff. I shortened that up quite a bit. Just cleaned it up a little bit, but I just wanted to paint a picture of what I told my mother when she returned back home. I had asked my mom earlier this year, what year was it my sister got married? Because I just didn't know how old I was at the time. 1978. I was 10. Little younger. He got home from work and she was mad as hell. For good reason. Thank you, Mom. She laid into it. I had that vision of him now, just leaning up against her, looking right through me. I said, I will kill you both. That stuck with me just a bit. That's my key inflection point that I deal with in the therapy. Everything kind of points to that. I'm just one of many people. I've heard worse stories. I'm sure that there's other people in this audience that have gotten through worse. Just sucks to have to do it. I don't really think it's wise to compare, one person's trauma to another person's as better or worse. Just, you're going to hurt somebody that needs help anyway, even if it's not what you think is trauma. PTSD doesn't go away. Excuse me. Doesn't go away. You can diminish its effects if you work at it. And it can play less damage on your life if you seek and get the treatment. Making it harder to access treatment by cutting funding as if I and others are a charity case is a very bad idea. Cutting these access also hurts the medical industry. Because if therapists if they're seeing less patients, then they're getting less experience as well, and they're learning less. And every time they learn more, that gets passed on to everybody else, all the way through. And the VA is the one that has been doing the mental health workload, and that they're passing it on to the civilian doctors. So cutting the VA is going to hurt everybody. It's going to hurt us. Hurts everybody in our population. I've made it a long way since 2007. But the analogy I use in my sessions is that I'm in a boat and I can see the land. I just can't get there yet. Yet being the operative word, I suppose. Our VA healthcare system has helped me, housed me, and just made me really get introspective a bit to kind of look at my problem. And man, you can challenge somebody else's problems all day long, but you challenge your own for a minute, and you realize how tough that is to do. Especially if there's something you think needs to be fixed. My last thought, I was born in 1968, and apparently there were 2 billion people on the planet at that time. That means it's doubled twice, just in my lifetime. And I'm not over yet. I got another 30 years if my plan is all right. Where's it going to be then? And where's it going to be 50 to 100 years after that? This diminishing healthcare, these healthcare cuts need to be expanded for those reasons, not diminished. Because we, the people, are the ones that are going to suffer if it's diminished. That's all I have to say. I want to thank you guys for listening to me.
Thank you so much, Stephen, for sharing your story of survival and having the courage to put a human face to the suffering and a human face for what is possible when you get the help you need. Thank you. So I'm going to take 4 minutes, and I can count on our timer to keep me to it. Before we go into healthcare, mental health care, to touch on 2 quick topics. Affordable Care Act and Medicare. So it's important to know that those new restrictions on lawfully present immigrants who do not hold green cards, the asylum seekers, survivors of sex trafficking, domestic violence, etc., who do not qualify for Medi-Cal, also will lose their coverage. The others who have slightly higher economic resource but who cannot afford private health insurance, their Affordable Care access to supplemented and subsidized Affordable Care Act and health insurance will cease January 1st, 2027. That is true for Medicare as well. So both affordable care. So basically, if you have those immigration statuses, you're out of luck. You're out of luck. January 2027. So quick update on Affordable Care Act. So currently in Sonoma County, about 50% of our residents have private insurance. Nearly 20% have private insurance through the Affordable Care Act health insurance exchanges. The Affordable Care Act is not going away in 2026. As it stands, it will no longer be affordable. The Affordable Care tax credits and subsidies are scheduled to expire at the end of this year, calendar year. The ACA health insurance premiums are expected to increase by 66 to 75%, rendering them unaffordable for many, if not most of the current folks who take advantage of that system. So we're going to see many more uninsured people. Now, Medicare. You don't hear much about Medicare, the big brutal bill. I mentioned that there are the new restrictions on the folks who are here lawfully and don't have green cards. There are the big brutal bill blocks improvement to the Medicare Savings Program for 9 years, which will increase the out-of-pocket expenditures for low-income Medicare beneficiaries. The increased out-of-pocket payments will be for premiums and medications. This is going to result in $66 billion of savings on the backs of the poorest beneficiaries to be routed upward to the wealthiest. There will also be blocks on the minimum staffing requirements for nursing homes, which result in decreased patient safety. That's for 9 years. And if there was more time, every physician and nurse practitioner and nurse in this room has a human face to that when there aren't adequate staffing in nursing homes. So the last one, before we hear about mental health access under the big brutal bill, is a little complicated, and it's not directly caused by the big brutal bill. So it is currently law that if there is a significant budget deficit at the national level, this will trigger automatic cuts to Medicare funding. Why haven't we heard about this? And that is because Congress has the ability to override those automatic cuts and fund Medicare fully, which is what they've been doing the past several years. And I'm just going to share a couple of numbers here. For the fiscal year 2026, we are scheduled to have a $45 billion Medicare cut automatically unless Congress acts to choose funding. Historically, that's been a foregone conclusion, but with the budget-busting big brutal bill, that is no longer a foregone conclusion. And over the next 10 years, this is going to result, if Congress doesn't act each year to authorize the funding, basically an act of Congress, it will result in $490 billion cuts to Medicare, and the savings will go you know where. So, just want to do an introduction now to mental health. Yes. So, yes, the National Alliance of Mental Illness is the largest grassroots mental health organization in the United States, supporting people who live with mental illness, their families, and providing the advocacy that's needed at local, state, and federal levels. Mary Frances Walsh is the Executive Director of NAMI Sonoma County. She will share with you the work of NAMI and will highlight the likely effects of the big brutal bill, as well as some Trump administration policies on the mental health of our community, and she will share opportunities for advocacy.
Thank you for having me. I come from a much smaller organization than my fellow speakers up here. But we have been in Sonoma County for 40 years. And we are not providers of clinical mental health services, but we provide education and support. We help people, especially families and individuals who are sometimes struck by the impact of mental illness. We help them understand these illnesses. We help them figure out how to get the right kind of care if they can, and we provide support because these illnesses are difficult, because they affect thinking and behaviors of individuals, and they make it sometimes very difficult to live with somebody who has a serious mental illness. So people need support and connection with others who get it. And I call this impact on behavioral health because increasingly talking about both mental health and substance use disorder treatment. And the fact is that so many of the people that we connect with and support live with both the mental health condition and a substance use disorder condition. They go hand in hand often. So I'm not going to repeat these statistics, but what I want to say is that I can't imagine that it would be very unusual if anybody in this room does not know somebody who is affected by a mental health condition, who has had an experience of suicide, whether or not it's a loved one, or somebody that you know is a colleague, a neighbor, or a young person. And suicide is a tragic event that impacts many more people than just the immediate family. Overdoses. Another tragic event that is affecting way too many people in our country. No family is untouched by these, and they all relate to mental health. And we all pay for a healthcare system that doesn't function as it should. And a healthcare system should include mental health and substance use disorder services because they are a part of our health. So Medi-Cal happens to be the single largest payer of mental health services and substance use disorder services in this country. And that's why any changes to Medicaid, Medi-Cal in California are going to have a tremendous impact. People on Medi-Cal who live with a mental health condition tend to have higher rates of chronic diseases. So I'm talking about heart disease, diabetes, metabolic problems. And they also have higher rates of substance use disorders. Too many people in this country that live with a mental health condition and or a substance use disorder don't get treatment for a variety of reasons. There are cost barriers, there's stigma barriers. We're doing a better job with stigma these days, but still, people feel judged by having to acknowledge that they have a mental health condition. And judgment is heavy for people with substance use disorders as well. It prevents them from seeking help, prevents them from talking about it, it prevents family members from talking about what's going on. And therefore, those are restrictions on accessing care. Many people with serious mental illness, and when I talk about that, I'm talking about somebody sometimes with schizophrenia, schizoaffective disorder, bipolar disorder, sometimes major depression. But the illness is so serious that they cannot function day to day or in their community. And many of them do get their care and their lifelong support in a long-term care situation in a nursing home. And again, Medi-Cal is a heavy payer. So I read a Journal of American Psychiatry that said that they had a wide span. 65 to 91% of residents of nursing homes actually have a mental health disorder. It's huge. So if we make changes that decrease access to Medi-Cal, what we're doing is decreasing access to care, whether we're deciding to limit the benefits that are available under Medi-Cal. And very often, because Medi-Cal is such a huge payer of these services, it sets precedents for commercial insurers, which often follow whatever Medi-Cal does. And cuts to Medi-Cal are going to worsen the existing provider shortage that we have in this country of people who provide behavioral health care. So, parity. So there have been multiple laws, both in California and at the federal level, that have been established to establish parity, meaning that mental health conditions deserve the same kind of treatment as physical care. We should not be limiting care for people who are affected by a mental health condition. So there's a 2024 law under the Biden administration that took another step to strengthen parity even further, because despite the laws, there is still discrimination, there's still not fair treatment between these two worlds of providing care. But 100 big employers in the United States gathered together and they fought that law, which the Trump administration has supported them. And so we're still stuck in a situation where the federal government is not going to stand up for saying, yes, you do need to provide mental health treatment on a par with physical treatment. So one of the small ways that that happens is that Congress cut the funding for a small agency, EPSA, I don't remember what that stands for. It's within the Department of Labor, but basically that is an agency that handles complaints. So if you are a patient or a family member who's had a bad experience with trying to access mental health care and it was denied, you might go to this agency to have a complaint investigated. But that staffing has been dramatically cut. So what that means is you're going to wait much longer for a decision about whether or not the insurance company was appropriate in its denial of care or not. There are going to be fewer investigations, and the result is more people going without care or delayed care, making the situation worse. So we do have a provider shortage across the country, especially in rural areas. Millions of people live in an area where there's not access to a psychiatrist, to a psychologist. And Sonoma County even has a shortage. I'm going to speed this up. But basically, Medi-Cal pays behavioral health providers among the lowest rates. I can't speak to an FHQC. But the reimbursement rates are really low, and that means that many people don't go into these professions compared to plastic surgery, for example. One of the things that concerns us, and I did this before the latest report was published, but the MAHA, Make America Healthy Again, which focuses on children, but some of their proposals are not all bad if they take a realistic look at what's happening and how we prescribe psychiatric medications for children. Look at overprescribing. Make it more difficult to provide care. But because this enormous lack of trust in the decision makers behind these decisions, it is very scary. One of them is requiring the Veterans Administration to provide data on the spouses of veterans and their dependents. What kind of prescriptions are they getting? And what kind of mental health care access do they have access to? I will skip this one because it's not my absolute. I want to say that President Trump's executive order on homelessness and mental health, you know, he used terms like, let's get back to institutionalization of those with very serious mental illness. We spent years building our way out of an era of institutionalization where people were kept against their will, sometimes for years, in a situation that may have started out with good intention. They eventually became warehoused in big institutions. We do not want to go back there. We want mental health conditions can be treated. We want people treated and supported, not locked away. And then there's this whole discussion of who qualifies for an exemption under the work requirements. People with mental health disorders do now qualify for an exemption, and they're expected to, but nobody knows how this is going to be defined. Who's going to be deciding? And how will people know if they have the right to an exemption? And what's the process for them to apply? How does it happen? All of this is very, very nebulous. And then I will just mention two things that have benefited from Medi-Cal and that could be at risk. You know, for years we depended on law enforcement to go help people in behavioral health crisis. And we have made very good progress here in Sonoma County with creating mobile crisis teams, which are civilians that go out and respond, trained to de-escalate, and address the situation and keep people increasingly out of our emergency departments and out of the jail, which happens way too often. And also we built a PUF, that's a psychiatric health facility. It's a 14-bed facility in Los Guadalajos, which is a new place to offer inpatient care for people who have been in crisis and who needed intensive treatment. Both of these were built with county funds, but the expectation is that they are moving into an era in which the services will be Medi-Cal reimbursable. The rates are quite good right now, but if those rates drop, these critical services are going to be in trouble. If all I can say for advocacy is just please just keep informed.
Thank you so much. So we're going to take about 10 minutes for Q&A, and then we'll do a little quick closing. Cards. So do you have the cards? Yes.
So tell them, you gotta tell them we're filling out.
Pardon?
Oh, yeah, here we go.
So people are walking down the aisle to collect cards.
Yeah, if anyone has a card you want to write a question on.
Yeah, we've got someone down here as well.
Yeah, this is raise your hand.
Yeah, beautiful.
Submit question.
Okay. So Lisa and Gabby, do you anticipate the federal government attacking California Health Services for continuity to provide care to undocumented people? It seems that they're making noises that they will penalize states who continue doing this. Will it make it impossible for health centers to be able to provide care?
So one of the things that has happened recently is that the federal government is now targeting Democratic states, blue states, and looking to see if we overcharged Medicaid. So if we used any federal funds to take care of the uninsured, and they're really focused on California. And so what they're looking is for ways to penalize us for inappropriately using federal funds. So I feel like this is the beginning of them really targeting the blue states. We have our Big 330 grant, which is our federally qualified health center grant, may change as a result of this. I'm kind of concerned that in addition to targeting California, they're also going to target specific services. So currently, we cannot use federal funds to pay for abortion. We can use federal funds to provide gender-affirming care, but I'm concerned that that may shift.
I would just add from the health plan impact level, there's probably two things I talked about that I didn't add detail, but there's a differential between states that expanded into Medi-Cal, which California did, and states that did not. And for example, I talked about this managed care organization tax. Well, for those of us who are in states that expanded, we have to reduce that pool of money to a lower level, a percentage lower than states that did not. So that's a little bit of an additional penalty in a way, maybe that's not the right word. And then the other thing is that for looking at people at the federal poverty level and how, I wish I could look at my slides again, but basically we had to look at people at 100% of the federal poverty level as one of the thresholds for how they would get benefits, whereas other states that did not expand into Medicaid could keep people at 110% of the federal poverty level. So there's a little bit of a differentiation, and those are subtle things, but I think there is a little bit of difference in some areas where states that expanded have to meet more stringent criteria.
This is a question, what about preventative health? So all of these cuts are going to reduce our ability to provide preventative health to everyone, right? Less funding means less resources, less staff potentially to provide the services. And if you don't have insurance, you're much less likely to come in for preventative health because it's going to cost you and you don't want to pay. Federally qualified health centers have a sliding scale, and we don't turn people away for inability to pay. But still, some people, even then, that doesn't cover specialty care, hospital access, all those things. But I think preventative care will definitely change. We won't be able to devote as much resources as we do now to bringing patients in and educating them on the benefits of preventative care.
So I have a couple of questions here. One is, are there predictions about hospital closures in Sonoma County? And I think this is a super reasonable question to ask, and I will just say with reassurance that at our level, as Partnership Health Plan, we have no information that we have any hospitals in our local area that are planning to close. So I say that with full transparency and candor, that is not something that we are aware of at this time. And then there's a couple of questions about the work requirements. So who enforces and oversees the work requirements? Also quite a good question, and this is a question really about how will this law that's come down be implemented, and I think that there isn't an answer to that yet. We don't know exactly, counties typically review eligibility, and so we do think counties have a role, but it's not totally clear, and I would say in the, maybe I don't want to speak for you, Gabby, but I think that we're facilitating conversations with health centers to understand just how we could participate as partners in this so that we can help our patients who are eligible for health insurance to actually qualify for it. And then the next question is, how will people get exemptions? I think that will be reviewed at the time of redetermination, so people will present their personal circumstances. And then here a very specific question, how long do folks get postpartum before the work requirement starts? And the answer to that is a year. So women and other people who are in their prenatal care don't have work requirements, and for a year after the delivery.
I have a question. I think it's a plant about how NAMI gets its funding locally. We are a 501c3. We're a nonprofit, one of those nonprofits that would so love to get a donation. But every year, for the past 3 years, we've had a NAMI walk event. We're having one in Howard Park on November 1st. It's an event that raises awareness about mental health. We will have we think we're going to have 24 community-based mental health organizations there to talk about their services and their programs. But we would love to have people there to stand up with us to say mental health matters. And we would love to, if you're thinking about a donation, we would love to be thought about. Thank you.
I have a question. The last time we had a crisis where we didn't really have the systems set up to address it was during COVID. And like so many other county public health systems across the nation, ours has been serially defunded by the Board of Supervisors. And that has happened over a period of 30 years. So when COVID hit, there wasn't sufficient staffing in our county public health to solve the problem. But what they did was step in, provide leadership, and help with coordinating the response, connecting with multiple stakeholders in the community, first for mass testing, then for mass vaccination programs. I wonder if you see a role for the county to potentially step in to help coordinate, especially around keeping people enrolled and avoiding administrative disenrollment.
Yes, there's definitely a role. I don't know what their plan is, to be honest with you. But I actually have a meeting tomorrow, so I'll be able to share more after that.
Yes?
I wanted to speak to that because I know that during COVID, the Sonoma County Medical Reserve Corps was brought into place. I was one of the people that spent hours on the phone calling everybody that had ever given anybody a shot, asking them to volunteer. I want to say that here in Sonoma, we had 900 people volunteer. 900 people, and this is everybody from somebody that was a guy that worked in the emergency room that did 12-hour shifts, all coming back to me, to pharmacists,
So that was a successful community effort, and
I will just say that from the plan level, we're really trying to have conversations both with clinics and with the county. And so I think we're all in the same vein, that we're really trying to collaborate and try to understand how we do this work the best we can in our community.
so we're going to be wrapping up shortly, but I just want to say that you've heard multiple opportunities to give, to donate, and for advocacy. I do want to call out Planned Parenthood again. as an institution who could use that support. And I want to call out the Jewish Free Community Clinic. That really is free. They have 4 exam rooms and staffed by volunteers, and they survive on a few small grants and our donations. And then the Redwood Empire Food Bank is also a place to consider. For advocacy, I want to call out Rob Bonta, our Attorney General, who has joined over 40 states Attorney General in multiple lawsuits to block the federal government's cuts to Medicaid, the ACA, and to Planned Parenthood. I do want to say that there is probably an opportunity for some advocacy at the state level with Chris Rogers and Mike McGuire, because the state gets to interpret what constitutes disability, mental health, and substance use disorders. And let me tell you, there are so many ways that could go wrong. So, and Mary Frances may have some specific recommendations for people, but letting your state assembly people, as a person and senator, know that we want generous work requirements so that folks can, who need the health care can get it. And lastly, Jared Huffman and Mike Thompson. You know, I heard today that Chuck Schumer and Hakeem Jeffries both said that they were going to block this next budget passage if there weren't a reduction in Medicare cuts and more money placed back into ACA. I will believe it when I see it. At the same time, it's an opportunity for advocacy for our reps to say, tell their leaders to stand firm. With practice, it makes perfect. So that's it for this evening, except for one thing. We have been addressing the urgency. And just like with our democracy, we don't want to build back what got us here. And we have a fractured healthcare system, and we don't want to go back to that. Moving forward, when we have the capacity in the government, we want to do more than that. We want to provide high quality, affordable health care that's efficient and effective for all who live here. And I want to give 1 minute, and that's all you have, Terry, as the man standing here for health care for all.
So many say, why organize now around universal health care for residents through a single-payer system when fascism is looming around all of us? And but we think that it's important to fight these cuts, to fight for health, but also to not just be reactive. The reactionary Project 2025 has taught us something. And in order to be successful, we must have our own Project 2029 to remind all what we stand for. So we live in a deeply polarized country, and if there's one issue where we can quickly find common ground, it is healthcare. It's a really powerful tool for reaching those even who don't agree with us on very many other issues. Single-payer system, I won't get into the details, but it is very powerful in a way that can provide lower costs, care for everyone, and I mean everyone, and provide a richer set of benefits than any of us on Medicare, Medi-Cal, or private insurance currently get. If this is something, I mean, basically the state of California now, we have helped pass a bill that's been signed by the governor with a planning process in place to create a unified financing system in California, which would be paid for by progressive taxation for the wealthiest and large corporations and save more than $500 billion in the first decade alone. So this is a possibility in California. We have the 4th largest economy in the world. And so we can do this. Yes, we're going to need a more friendly federal administration, but this is a long-term planning process. We need to fight for a better system of care for all of us. So if this is something that makes sense to you, please connect with us. Thank you.
Thank you, Terry. Thank you so much for coming out. Stay active, stay focused. 2029